At Axxess, we believe that teaching what we learn helps everyone to grow. You can count on Axxess to continuously create and present content to help your staff and your agency thrive in today's quickly changing environment. Before we begin, I'd like to share a little background about Axxess. Axxess is a technology company that provides software for health organizations to efficiently run their business. We empower healthcare companies with an easy-to-use, cloud-based software that integrates all aspects of their operations so that they improve patient outcomes while growing their business. We are the fastest-growing home health technology company in the country today, and also the #1 recommended home healthcare software by users just like you on Software Advice. Over 90,000 users log on to Axxess daily, representing over 1,800 agencies serving over 500,000 patients across the country today. Axxess has achieved many firsts in the industry. We are the first and only home healthcare technology company approved to award CEUs by the American Nurses Credentialing Center. We are the first and only company to have a native mobile app that works on both Apple and Android devices. And Axxess is the first software company approved to conduct CAHPS patient experience surveys. Now, as promised, let's start today's webinar so we can give you the knowledge to help grow your business.
Hi, this is Jennifer Gibson with Axxess. I'm very glad to have you with me today on our new ICD-10 coding series. Today you're going to be learning about navigating the highway of ICD-10-CM. In Part 1, you're going to learn about ICD-10-CM guidelines and conventions, and we're going to get started. Your objectives for today is to understand why proper coding is important, to learn who is to assign the diagnosis codes, the importance of official guidance and conventions, why using gems or mappings is not a smart practice, the steps in coding properly, how to properly code using the guidance and conventions that we're going to learn, and then what the OASIS C1 guidance manual says about diagnostic coding. Let's talk about the transition to ICD-10-CM. The transition to I-10 from I-9 may be having a major impact on your home health agency. As I've traveled all over the country, what I'm learning is that our productivity estimates that we had gleaned from other implementations in other countries. Lastly, in Canada, they implemented several years before we went through our implementation of I-10. But what we're learning is that the projected productivity decrease of 50 to 70% has kind of remained true in agencies. We know that the transition to ICD-10 was not optional if you're a HIPAA-covered healthcare provider, so most everybody had to go over to ICD-10 from ICD-9. Basically, if you were using an ICD-9 code, you have to code an ICD-10, right? And so what I'm learning from agencies as I talk with them is the productivity with coding in ICD-10 that was expected to drop 50 to 70%, that is actually true. And a lot of that comes from having to dual code for those claims that spanned the implementation date of October 1st. We're also learning, of course, just because we don't have these codes memorized like we did in ICD-9, that it takes longer to look them up and apply the rules and check and double check to make sure you have the correct code. Now, one thing that's important to know is that productivity will get better as time goes on. But the studies with the Canadian implementation, and they were the last one again to go to ICD-10 before the United States, what we learned is that productivity decline lasts even past 12 months later. But it does come up to about 20% less after 12 months rather than the 50 to 70%. So again, I'm pretty sure that the transition to ICD-10 is affecting you right now, and it has the potential to continue to affect you in the future. So a little bit about ICD-9. Now that we've transitioned to ICD-10, you should know the last update to the ICD-9 code set was October 1st, 2013. There will be no further updates to ICD-9 because we've already transitioned out of that to ICD-10. And it's officially retired, as you see the little comic over in the corner. ICD-9 is now enjoying retirement. However, we don't want to throw away those ICD-9 codebooks just yet. You need to keep those around for at least 5 to 7 years because you may get an audit or some kind of a legal summons that you might need to go back and refer to those codes. And if you get rid of your code book, you certainly won't have a reference tool. So make sure you take that code book and lock it away somewhere safe that perhaps a well-meaning person might grab it and think that it's not needed anymore and take it home and play with that ICD-9 code book for some reason. Just make sure you have a copy on hand, okay? All right, so ICD-10 implementation, as we all know, occurred on October 1st, 2015. Agencies will still need both the ICD-9 and ICD-10 code systems for a period of up to 14 months. The reason, of course, for that is that we have a year to go ahead and bill our final claims after the episode has ended. And so if you need to go back and make corrections or rebill those particular claims that occurred before October 1st, you will need to code those in ICD-9. And then anything after October 1st, as far as final claims, we need to code those in ICD-10. And then, of course, we have those tricky payment episodes that spanned the implementation date. And so for some of those that span the date, let's say they started in late September and go over into October, your wrap, of course, had to be billed in ICD-9, and then the final, once we've passed the through date of the episode, once that has passed October 1st, that final then has to be coded in ICD-10. So until all of those different bills have been completed and processed, you'll need both the ICD-9 and ICD-10 code sets for a while. Remember, there's no grace period for ICD-10. We basically flipped a switch on October 1st, and CMS no longer accepts ICD-9 codes for any dates of service October 1st or after. Now, as we have learned before in the Introduction to ICD-10 webinar, CPT codes and HCPCS codes, and CPT are those current procedural terminology codes that are most often used in outpatient settings. And HCPCS codes we do use in home health care. Those are the codes that are associated with services and supplies and things like that. Those codes were not affected by this transition to ICD-10. And once again, ICD-10 is used by all HIP providers who used ICD-9 codes. So what are the benefits of ICD-10? Why are we bothering with all of this? Number one, it has updated terminology that's consistent with current medical advances. If you think about how old the ICD-9 code set is, and you see how much expansion there is in ICD-10 once you get in there and work with it, you realize that there were quite a few changes that were needed in order to stay consistent with current medical advances. We also have an increased flexibility for future updates. There was no more room to add codes to ICD-9-CM, and because of the structure of ICD-10, we're able to go ahead and have room to add codes and make those more flexible for future updates to the code set when they add new codes or remove and so on. We also have the ability for more enhanced coding accuracy and specificity. As you know, we have laterality added in ICD-10, so we can cover the right and the left, in some cases also bilateral. An example of laterality would be bilateral knee osteoarthritis. We also know that there's a lot more specific information as far as the types of the diseases, and it breaks it down, and the code titles flow throughout the codes themselves. So the benefits of ICD-10 also would support refined reimbursement models, and what that means is because of the specificity of the ICD-10 code set, you can now code, for example, liver failure with ascites versus liver failure without ascites and so on, and that gives the entities that be the ability to refine case mix or reimbursement so that, let's say, a non-healing fracture would get more reimbursement than a routinely healing fracture, or that liver patient who has ascites would get more money than the one who does not have ascites, for example. So we have the ability, we haven't seen it just yet to its full extent, but in the future, I wouldn't be surprised to see that we get more refinement between those different specific codes. ICD-10 also gives us the ability to effectively detect and investigate potential fraud or abuse. So, CMS is always interested in making sure that we can spot and track fraud and abuse quite easily. And those of us in the industry who are doing the right thing are quite glad that they're able to spot those true fraudulent and abusive agencies and get that either educated or under control in some other way. And last, we have improved operational processes across the healthcare industry that we know that eventually in the future, all of the different healthcare settings will be coming together and sharing information between each other. And so now that we're all speaking the same language, ICD-10, we can speak to hospitals and outpatient settings and link up in the near future, hopefully, to get information from each other. And also on a more global scale, we'll be able to track effectively outbreaks of flu pandemics or other types of issues, Ebola, because we are all using the same ICD-10 code set now. All right, let's talk a little bit about the differences between I-9 and I-10 as far as how they're made and how the codes themselves look. This is important so that you get your head kind of wrapped around the ICD-10 code set and what it looks like. So ICD-9, of course, we know in I-9 the codes are 3 to 5 characters in length. In ICD-10, the codes can be 3 to 7 characters in length. And just like in I-9, not every code was 5 characters long. In ICD-10, not every code will be 7 characters long. Codes can be 3 or 4 or 5 or 6 or 7 characters in length. In ICD-9, the first character was always alpha or numeric, and the 2 alphas that we used in ICD-9 were E codes, E as in elephant, and V codes, V as in violin, and those were used periodically. We used a lot more V codes than we did E codes. The E codes were external cause codes, and we seldom use those, but you could use external cause codes to describe where a fall took place, for example. In ICD-9, characters 2 through 5 were always numeric. Now, the structure changes quite drastically in ICD-10 because in I-10, the first character is always an alphabet letter. The second character is always numeric, and characters 3 through 7 can be a mixture of alpha or numeric. So as far as the first character, by the way, the only alphabet letter we do not use is the letter U, as in ukulele, and they've simply reserved that for future expansion if it's needed. As we said earlier in the presentation, the space for new codes in ICD-9 was quite limited. We just literally ran out of space to continue to add codes. But because of the change in the structure, we now have alpha and numeric characters that we can add into the ICD-10 code after the first couple of characters. We now have much more flexibility on having space for new codes. And as we well know, ICD-9 detail was quite ambiguous, whereas in ICD-10 detail is very specific. In ICD-9, we did not have placeholders to deal with. In ICD-10, of course, there is a dummy placeholder X. In I-9, the alpha characters were case sensitive, which means if you used a V code, for example, a V code for therapy only, if you didn't capitalize that character, the alpha character, your claim would reject. In ICD-10, that's not the case. The alpha characters are not case sensitive, so your X's and your A's and whatever can be uppercase or lowercase. In ICD-9, there was no laterality. You couldn't designate if a pressure ulcer was on the right side or the left, for example. And in ICD-10, of course, there is laterality. Now, where you see brilliantly illustrated, I think, the difference between I-9 being out of date versus I-10 being very up to date is the number of diagnoses and procedure codes in each code set. In I-9, there were barely over 14,000 diagnosis codes. In ICD-10, we go up to almost 70,000. There are 69,099 diagnosis codes. Now, procedure codes, although we don't use those in home health care, you'll notice just how out of date the procedure coding part of the code sets were. ICD-9 had barely under 4,000 procedure codes. ICD-10 has nearly 72,000 procedure codes. So I don't know about you guys, but I'm quite thankful that we don't have to code procedures, because my digging through 3,800 procedure codes to find what I needed was cumbersome enough. But I cannot imagine having to dig through 72,000. So the hospital-based and outpatient clinics and such that have to do procedure codes, they certainly have my respect. I don't have to deal with that, and I'm quite thankful. A couple of other major differences. In ICD-9, the injuries were grouped by type. So all of the lacerations were grouped together, all of the fractures, and so on. In ICD-10, however, injuries are grouped by anatomical site, which means if you have an injury to the head or you have an injury to the forearm, then it's broken down after the location is stated, all the different injuries that can happen to that particular body area or anatomical site are listed. And just as an example here, we have two different codes that describe a fracture of the radius. In ICD-9, you'll see just how vague it is. You have 813.15, open fracture of the head of the radius. In ICD-10, you have S52.123C, which is a displaced fracture of the head of the unspecified radius, initial encounter for open fracture type 3A, 3B, or 3C. Now, I will go ahead and tell you this. Please don't do what this example has and use an unspecified radius. Certainly, as home care providers and clinicians, we would be able to deduce which radius is affected. So you would want to see laterality there instead of unspecified. You would have right or left, okay? The code structure in I-10, again, you can see here on the left-hand side we have the ICD-9 code format. You had 3 character category heading, then you had a decimal, and the 4th and 5th characters were all that we had to describe the etiology, the anatomic site, and the manifestation. In ICD-10, of course, you still have the 3 character category level, the first 3 characters. The decimal stays in its same place right after the 3rd character, but then we have an additional 2 characters that we can add. So in positions 4, 5, and 6 of the ICD-10 code, that's where we describe the etiology, the anatomic site, and manifestation. And then the last part in the 7th character is an extension, and we're going to talk about what that 7th character does. And primarily, the 7th character is used in injuries and poisonings and burns and things like that. But that extension will describe which encounter the patient is being seen for, if it's an initial treatment for that particular problem or subsequent treatment or sequelae and so on. Let's talk a little more about that code structure in ICD-10. So again, ICD-10-CM codes are composed of codes that have 3 or 4 or 5 or 6 or 7 characters. Now, the 3 character codes are the heading of a category. So just like we had in ICD-9, if you were looking at 250, that was diabetes mellitus, and every 250 code related to diabetes mellitus. The same happens in ICD-10. The first 3 character codes are going to be the heading of that category. For example, E11 codes, which are diabetes mellitus type 2 codes, every E11 code is going to be a diabetes code, type 2 diabetes more specifically. And then as we saw in the diagram in the preceding slide, the 4th, 5th, 6th, and 7th characters provide greater specificity, more information about the anatomical site or the etiology or the manifestations and so on. And the 3 character code in ICD-10 is only to be used if there's no further subdivision. So all of that just to let you know that there are a lot of similarities and there are quite a few differences, but in the end we're going to just keep calm and keep moving and learn what we need to code in ICD-10. So bear with me as we finish up the differences in the 2 code sets, and we're going to talk a little bit now about the 7th character in ICD-10. Now, in the 7th character, again, it's only featured in some codes. But just like in ICD-9, if a code requires a 5th or a 6th or a 7th character, and it's not added, that code is invalid. For example, in ICD-9, if you had 250.40, and that code requires obviously a 4th and 5th character. So if we didn't add the 0 on the end of that code would reject and let us know that it's an invalid code. The same happens, of course, with ICD-10. If the ICD-10 code requires a 7th character and we leave it off, that code will be invalid, and of course the claim will reject. The 7th character will indicate which encounter is being treated when you see that. Again, most of the time this has to do with injuries. And for the most part, with the exception of fractures, the 7th character will either be an A, a D, or an S. The A in the place in the 7th character represents initial treatment, and that's when the patient is first seen for this particular problem. And that would most likely happen in an emergency room or a hospital or a hospice perhaps. D is for subsequent treatment. That most often is going to be what we use in the home care setting. And then S in the 7th character position stands for sequelae. Now, sequela means that the original diagnosis has healed, or the original problem, the original disease, that has actually healed, and now you have complications from that. For example, if you had a burn on your wrist and your forearm, and that 2nd and 3rd degree burn healed, and then you had contractures and scarring in that area, and now OT needs to come in and PT to teach you how to do your ADLs because of the scarring and the contractures, then that code would be an S at the end for sequelae, showing that the burn has healed. Now we're dealing with complications from the burn with the scarring and the contractures. Now I will go ahead and clarify a little bit. CMS recently put out in the final rule that for home care, we can actually use an A at the end in the 7th position in some circumstances. And one of the circumstances they mentioned had to do with a patient who's seeking treatment in the hospital for a condition, and they receive a couple doses of antibiotics, for example, and then they go home to the home health agency with continued antibiotic therapy. In that case, an A at the end would be the proper 7th character because we're still treating the initial problem. Maybe it's a dehiscence or an infection, post-surgical infection, something like that. So the diagnosis is exactly the same in the hospital as the home care because we're doing the same treatment for that initial problem. However, subsequent treatment would mean something, for example, the patient fractures a hip, they go to the hospital, they're diagnosed, that hip fracture is treated, and then we're going to send them home to home health care. We're going to receive them for supportive treatment as that problem heals and continues to heal and get better. In that case, we would use a D for subsequent treatment, or some of the other fracture 7th characters like G or H or whatever that show subsequent healing. So there's a little clarification again in the final rule. Initially, we were told that we would only be using the D for subsequent treatment, and then the final rule came out and gave us some clarification, and they also updated their case mix beginning January 1st, 2016, so that in some cases, the A at the end will receive case mix points just like the D at the end of that same code did in October to January of 2015. Alrighty, so again, the 7th character in ICD-10 and fractures, it also indicates the encounter and whether or not the healing of that fracture is routine or delayed, or if it's a non-union or malunion. Now, sometimes you're going to have instances with injury codes when you have to use a dummy placeholder X. And what that means is that 7th character is required, but the code itself contains fewer than 6 characters. And in that case, you would have to add an X in between the 5th character and the 7th character, and then add the A, D, or S or whatever at the end. So just be particular about making sure that when the 7th character is required and the code is too short, it's maybe 5 or 6 characters long, you may have to use an X placeholder, okay? Some examples of code links. One of the 3-character ICD-10 codes is I-10. Isn't that ironic? I-10 is essential primary hypertension. There's no more, of course, hypertension tables in ICD-10, and all of the hypertensions pretty much are I-10 unless it's hypertensive heart disease or hypertensive chronic kidney disease. Those are coded to a different category. A 4-character example would be L60.0 for an ingrowing toenail. That sounds terribly painful. A 5-character ICD-10 code would be R39.15, which is urgency of urination. A 6-character code example would be M62.421, contracture of muscle, right upper arm. And then an example of a 7-character code is T46.1X5A. This is an adverse effect of calcium channel blockers, initial encounter. An example of the 7th character for fractures in this case, just to illustrate that in fractures they're not always A, D, or S, the code would be S42.362G, and that's a displaced segmental fracture of the shaft of the humerus, left arm, subsequent encounter for fracture with delayed healing. You can see just how specific these codes are. So again, going back to case mix refinement, if you have a fracture that's healing routinely versus, in this case, a fracture with delayed healing, CMS at some point may likely come in and award more case mix points for this particular code than they would for the routine healing. Again, this is just my hypothesis at this point, but I wouldn't be surprised at all that that would happen. Again, the placeholder X is not case sensitive if you have to use that in ICD-10. An example of the placeholder X, in the first example here, the T46.1X5A, the X placeholder in this case was already there. Okay, so we don't have to worry about adding it. They only had to add the 7th character. And this code is adverse effects of calcium channel blockers initial encounter. And again, it doesn't matter if that A is uppercase or lowercase. And then the second example here, we have T15.02XD. That's a foreign body in the cornea, left eye, subsequent encounter. In this case, the code itself was only 5 characters long. It's T15.02. And so to the left of that code, if you're looking at it in a code book, you would see an X7, which lets you know you have to add the X after the 2, and then also add the 7th character A, D, or S to show which encounter this patient is being treated for. All right, you're going to notice in ICD-10, if you haven't already, there are a lot more combination codes in I-10. For example, you have I-25.110 for atherosclerotic heart disease of native coronary vessel with unstable angina pectoris. You have an example of E11.311, type 2 diabetes with unspecified diabetic retinopathy with macular edema. And that's important only because you notice in I-9 your atherosclerotic heart disease codes did not have with or without unstable angina and so on. And your diabetes codes, to code that same problem in ICD-9, that would have taken 3 different diagnoses codes. You would have had your diabetes with ophthalmic manifestations, and then you would have to code retinopathy, and then you would also have to code macular edema. But in I-10, there's a combo code that takes all 3 of those problems into account, and it's covered with one code here. The next example, we have K71.51, toxic liver disease with chronic active hepatitis with ascites. And of course, if we have a code that says with ascites, quite often there is a code that says without ascites as well. And then the last example we have is Crohn's disease of small intestine with intestinal obstruction. Okay, again, just to show how much more specific ICD-10 is than ICD-9, you have an ICD-9 code here for V54.9, unspecified orthopedic aftercare. And then we had to put over in 1024B that buddy code for the fracture itself, 820.03, fracture of the neck of the femur, base of neck. So that really didn't tell you a lot. You just knew you're going to do some kind of orthopedic aftercare, likely going to be therapy. And the reason for that was a fracture of the femur, but you didn't know if it was the right side or the left side, but you only knew it was at the base of the neck of the femur, right? So when ICD-10 came out, and you can see from this code, we have a lot more information. S72.044G is the code we used, and this is a non-displaced fracture of the base of the neck of the right femur. It's a subsequent encounter for closed fracture with delayed healing. That just gives you so much more information about what's going on with your patient. Another thing you'll notice as far as specificity as it relates to stroke patients, in ICD-9 it was pretty vague. You only knew that it was hemiplegia and hemiparesis affecting the dominant side, and we know that was a late effect code. It was really non-specific. The code we have here is 438.21. In ICD-10, however, you'll notice the code title follows through, and you can see exactly what's going on with this patient. In I-69.351, you have hemiplegia and hemiparesis following a cerebral infarction affecting right dominant side. So while it's still a late effect code, you know specifically what caused the hemiplegia and hemiparesis. Whereas with the late effect in ICD-9, you may have been wondering if it's due to a stroke, or was it a hemorrhagic bleed in the brain, or was it a traumatic brain injury? What exactly happened here? You would have to use additional codes to show that. And in ICD-10, we have a combo code that gives us all the information there. Now let's talk specifically about the OASIS and coding. We're going to get into the guidance now. I wanted to clarify a little bit about the code set itself, so that we set up why learning to code properly is such a big deal. Now, we know the OASIS C1 ICD-10 version also began on October 1st. We had already transitioned to a new OASIS C1 in January, but we have a new version of OASIS C1 October 1st to accommodate the 7 characters possible with ICD-10. So the procedures, of course, are not coded in the ICD-10 version of OASIS. We didn't have those in the ICD-9 version of OASIS either, because they eliminated question M1012, which was the inpatient procedures, and we didn't have to worry about that. So OASIS C1 ICD-10 version, what they did, they took those ICD-9 version questions, the M questions, and they replaced them with M1017, M1019, M1021, M1023, and M1025. So you won't see the old 1016, 1018, 1020, 1022, or 1024 in the new version that began October 1st. Now, here's where we start getting into the meat of why we're in the webinar today. With the OASIS C1 and coding, you know, there's 2 different factors to think about. One, you have to fill out the OASIS properly, and 2, you have to make sure you're coding properly. So sometimes you'll wonder, okay, well, how do I know which one I'm supposed to do? Well, according to the OASIS C1 guidance manual, when you look specifically at the guidance for M1021 and 1023, you'll notice that the ICD-10-CM coding must follow the official guidance for coding and reporting. So that's why we're talking about today what the official guidance and coding and all of that is. Now, the official guidance for coding and reporting is put out on a yearly basis, and so for that reason, you need to make sure that you budget in your yearly budgets the expenditures for getting at least 1 new code book each year, because those new code books will have the official guidance for coding and reporting. Now, CMS also puts out the official guidance yearly, but you would have to keep up with that in a separate binder and make sure you reference that with your new code set, or I should say the new guidance to the old code book that you have in the code set. So for that reason, I recommend that you just budget in the $300-400 that you might need to get your new code book each year. The official guidance for coding and reporting is developed by CMS and NCHS in conjunction with questions and updates and refinements, like in the final rule, for example. They will add that into next year's official guidance. And of course, CMS is the Centers for Medicare and Medicaid Services, and NCHS is the National Center for Health Statistics. So between those 2 entities, they come up with the official guidance for coding and reporting. And adherence to that official guidance for coding and reporting is required under HIPAA. So for those 2 reasons alone, the OASIS tells us we have to follow their guidance. Now, what I tell my classes is that you need to think of the official guidance for coding and reporting much like the rules in advanced math. We know, having taken geometry and algebra 2 and trigonometry and so on, that there are rules that we have to apply to advanced math computation. And certainly if you don't learn and sequence the math problem properly according to those rules, you'll get an answer all day long, but that answer will not be correct. So the same concept really applies to coding in ICD-10. You need to know those rules, and you need to know where to find them if you don't know them by heart, and then you must apply them to coding in order to code properly. So again, ICD-10 coding rules and sequencing guidelines must be followed according to CMS, and the rating on the OASIS for symptom control is not to be considered when you sequence your primary and secondary diagnoses. So you may have somebody that has a number 3 or a number 4, which means that particular problem is more acute and requires more changes and more hospitalizations, but that doesn't necessarily mean that that diagnosis would be the primary diagnosis. Okay, and let's talk about what that means a little more. According to the OASIS C1 guidance manual, the primary home health diagnosis, that one that you're going to put in M1021A, is the chief reason the patient is receiving home care. That diagnosis is most related to the current home health plan of care, and only current diagnoses can be used, and that's both for primary and secondary diagnoses. So if it's not a current issue the patient has, we can't code that anyway. But again, the primary diagnosis is the chief reason the patient is receiving home care, and we need to make sure that that matches the face-to-face encounter form or the certification documentation that we get from the physician. The secondary home health diagnoses are those that are placed in M1023B through whatever letter of the alphabet you end up with. Those are comorbid conditions that exist at the time of assessment, and those things that are going to impact the patient's ability to get better. And then those secondary diagnoses must also be actively addressed in the plan of care or have the potential to affect the responsiveness to treatment and rehab prognosis. So again, when you think about only those current diagnoses and any other diagnoses that are going to affect the responsiveness to treatment or rehab prognosis, or anything that you're going to treat actively in your plan of care, then you may have a short list or a long list of diagnoses, right? So we know, according to that guidance, for secondary diagnoses, we should always code problems like diabetes and CHF and hypertension, because they do have the ability to affect the responsiveness of treatment. So who can select the diagnoses? According to the OASIS C guidance manual, which is pretty much CMS's rules or directions on how to answer the OASIS properly, the OASIS C1 guidance manual tells us that the patient's primary and secondary diagnosis must be made by the assessing clinician. So quite often what agencies will do that's incorrect in this aspect would be that the assessing clinician would go out and do the assessment, and then maybe they would call in a report and they would leave all those diagnoses blank or put a dummy diagnosis in, and then whoever does the QA and the coding would go in and add the diagnoses, the titles, they would sequence them and everything on their own. But what CMS distinctly tells us is that that primary and secondary diagnosis has to be made by the assessing clinician. And they go on to say that the clinician is expected to understand that patient's overall medical condition and the care needs before they select diagnosis. So in order to select a diagnosis, you have to have the big picture of what's going on with that patient. What specifically are we in the home for? What is their greatest need? Are any of the comorbid conditions out of control that are going to factor in the healing or the diagnosis treatment for that patient? For example, if the patient has a non-healing surgical wound and the nurse goes out on the admission and assesses that their diabetes is out of control, they're running blood glucoses in the 300s and 400s, of course that's going to affect their wound healing, because it's not going to heal properly if the blood sugar is elevated. So again, the clinician has to make that general assessment and understand their overall medical condition and needs before they select a diagnosis. That's also why once they turn that in, another person can't very well go in and pick out all the diagnoses and add them and sequence them because they don't have that complete picture on the assessment in person. Now, again, diagnoses by the clinician are based on assessment findings, the medical record, and input from the physician. So again, we need to know what's on the final copy of the face-to-face encounter, why the physician referred the patient to home care, and so on, and those things need to match. So according to the OASIS C1 guidance manual as well, the assessing clinician should then record the primary and secondary diagnoses in 1021 and 1023. Now, they do address what the coder can do in the guidance, and what they tell us is the coder can add the code after the assessing clinician has determined the primary and secondary diagnoses. So, you want to make sure that your clinicians have the ability to pick from a list or do some kind of way that they can add a diagnosis. And if your software company or the way that you document will not allow you to leave a code title without a code, so the coder can come back and add the code itself after the clinician has written in or typed in the code title for what's going on with the patient, then you're going to have some processes in place that describe how you're going to handle that. But the assessing clinician should be the person who is determining the primary and secondary diagnosis. So a little bit more information according to the OASIS C1 guidance manual for M1021, 1023, and 1025 coding criteria. You notice CMS tells us that coding and sequencing of the codes by a person other than the assessing clinician is not considered a technical correction. What that means is it's not, in their opinion, just a little tiny tweak that's going on. They actually consider this to be quite a big deal. So the coding specialist may not automatically make the correction without consulting the assessing clinician. So sometimes you're going to have field staff, and I was one of those persons in the field early on in my career that didn't know anything about coding. So I would write in what I thought was correct, and I didn't realize that there were sequencing rules and other things that impacted what I put down. So of course I would put it down incorrectly. And thank goodness our QA and instructor would be kind enough to give me a call and say, hey, just want to let you know that while, yes, you may be in the home because of falls, and those falls are due to neuropathy, and that neuropathy is due to diabetes, you really have to put diabetes before neuropathy according to the coding guidelines. So then we would have a conversation, and we had an agency-approved form in which we would write down on one side the initial responses that I had placed, and then on the other side in another column, the QA person or the coder would write in the correct responses. We would have a little note that we had a conversation. We would do a communication note as well, and then I would sign that, and the QA lady would sign that as well. And that's how we showed that we did consult with each other and that some counseling went on and that we both agreed at the end, and this was not a technical correction, but it was something that needed to be corrected. So your agency policies should address how and or by whom those changes are made. And you need to have some way in your policy to show that the conversation actually took place and that someone didn't just go in and assign codes instead of the assessing clinician, okay? So let's talk about some general coding review. We're at the point now that we're going to talk about the actual coding process and what we need to do to make sure that we code properly. Number one, coding begins at referral. So if you don't know what that means exactly, whenever you start getting referral calls or information in, you start scanning that information, trying to pick up on why it is that we're going to see the patient and what other comorbid conditions they may have that are going to impact the patient's care, and in some cases the cost factor related to that and whether or not you can handle this patient with the acuity and the services that you provide. So adequate information from the referral source is required. You need to make sure that whoever's gathering your referrals know enough about coding and patients and problems to scan that and start looking for coding information. And make sure that the referral source is also asked for the following documents. Number 1, the certification documents, including the face-to-face encounter that should have occurred according to CMS's guidelines, the history and physical, the clinical notes, the operative reports, and lastly, your discharge plan and discharge summary, because quite often that discharge plan, discharge summary will tell what it is specifically the patient's being discharged home with, and we all know that those diagnoses can change from the initial suspicion to what it was finally decided at discharge. And so that discharge plan and summary is going to have more accurate information as far as diagnoses go. It may also contain all the points that you need to prove the patient meets the needs or the qualifications to receive Medicare-funded home health, and your certification and face-to-face encounter and so on. For general success, make sure that the admitting clinician has all the referral information. And of course, that's important because, as we all know, going into patients' homes, these seniors and disabled persons, they don't quite often have only 1 or 2 things going on or 1 or 2 diagnoses. Quite often they have a myriad of comorbid conditions and problems. And if you don't have documentation as to which one is the one that you're sent to the home for, you may decide incorrectly as an admitting clinician what diagnosis you're going to be treating. We also need to make sure that that clinician has the referral information, because the clinical documentation has to support the coding that we use on our OASIS and our plan of care. We must remember, of course, the primary reason for home care is the primary diagnosis. And after the primary diagnosis, your sequencing is based on the acuity and the services that you provide. So again, you're going to sequence those diagnoses depending on who's making the most visits or what particular disease is getting the most visits and so on and so forth. We also know we have to code unresolved conditions, any comorbidities that impact the care, and any status codes and other codes that paint the picture of the care that we're providing. Now let's talk about the parts of the code book, because once we've deduced kind of what we're supposed to code, then we have to actually look up the codes and figure them out. Now I will say this, going forward, the code book is going to be your best place to get a code. Our software and many others, yes, we do have lists of diagnoses, and they are absolutely just that. They're just lists. They have absolutely no guidance, no rules, no regulations, or anything else. They're just a pick list. So if you're using a pick list only, you may miss some of the coding guidance and not be sequencing properly or using 7th characters incorrectly and so on. So for that reason, if you don't yet have a 2016 ICD-10 code book, you need to get your hands on one as soon as possible. And so what we're going to talk about going forward here in the presentation are the parts of the code book and then how to use that code book to get the proper diagnosis code. Now, if you have a code book, you know the very first part of that code book is the alphabetical list. It's the first listing in your code book most of the time. There are a few publishers that will change the format or where these different parts are, but I know Decision Health and Optum and several of the other code books, the alphabetic is the first listing in the code book. You never ever want to code from the alphabetic list directly. So if your practice with the code book is to look it up in the alphabetic and jot that code down and keep moving, you're going to make big mistakes. Never ever code just from your alphabetic list directly. To code properly, first you need to review the medical record and extract all pertinent diagnosis information. And what I usually do is have a little piece of paper or something and jot that down as I go. And then once you've figured out what all the diagnoses are that you want to look up, then you start to look them up in the alphabetic index, and you're looking for conditions or injuries or signs and symptoms or some key phrase from that diagnosis listed to find the code properly. Now, once you find the code in the alphabetic listing, you're going to read all the pertinent information and then check it in the tabular listing. Now, the tabular list is the part that follows the alphabetic list, and it's the second part of the book where you flip by and there's chapters, chapter 1 through 21 in ICD-10. and it's a numerical listing by chapters. So all of the AB codes are in Chapter 1, for example. Now, each chapter is classified by etiology or the specific body system, and the tabular list classifications and chapters explain the details of how coding a particular condition has to be done. And you're going to see in the tabular excludes 1 notes and excludes 2 notes, which give more guidance on how to code. Now, if you flip back between the alphabetic index and the tabular, there are some tables that you'll notice as well. The neoplasm table is one of those, and that's found at the end of the alphabetic index, or just after the alphabetic index of your code book. Now, the neoplasm table in ICD-10 is almost identical to the neoplasm table in ICD-9. The biggest change, or the major change, is that codes that are listed in ICD-10 on the table that have a dash, that means that that code requires a 5th character to add laterality. And not all neoplasm codes in ICD-10 will have laterality, but if you see a dash on that neoplasm table, that means you have to add an additional character. And so just like you don't code directly from the alphabetic index, neither do you code directly from the neoplasm table. So once you find the code on the neoplasm table, you have to also review the code that you find in the tabular list, which is the chapter indexed diseases. You have to go back and check there in order to find the choices for the 5th character, for the laterality, and so on. So in order to complete the code, you have to go into the tabular. Now, after the neoplasm table, you have another table, and that is the table of drugs and chemicals. Now, we had a table of drugs and chemicals actually in ICD-9, but we seldom ever used that. And we're going to be using it a whole lot more in ICD-10. And again, the table of drugs and chemicals is found just after the neoplasm table. And you'll notice on the top of the tables in the drugs and chemicals that there's a classification of drugs and chemicals that are associated with poisonings and adverse effects. So those headings are a little bit different because in ICD-10 you have a couple of new headings, one of which is underdosing. We didn't have underdosing in ICD-9, and certainly that's pertinent to us in home health because if you have to recertify a patient because they are underdosing on their Lasix and they had a CHF exacerbation for that, you're now able to code the CHF exacerbation as well as underdosing of their furosemide, and it really paints the picture of why you need to be in the home. You also have codes in the end of the book for underdosing due to financial hardship. So a lot of our patients will perhaps have some issues with paying for their medication, and they may be breaking their tablets in half to make them last, and that's causing medical exacerbations. Again, we have the ability to paint that picture and really describe what's going on. So again, the headings are a little bit different in ICD-9 on your drug and chemical table. The rows, which are down on the side, on the left, they go down, that would be the medications on the left side of the page. And at the top of the page, you're going to see the columns that identify the intent. So if it's a poisoning, that means the patient took the drug improperly in some way. And then there's some intent, whether it was intentional self-harm, or was it an assault, or was it something else, or we don't know, for example. In order to help you understand and figure out which of the columns to use, we have some definitions here of what the adverse effect versus poisoning and underdosing actually is. Now, an adverse effect means the drug was correctly prescribed, it was correctly administered or taken, but the patient has related side effects. So if I end up with a dry cough from my lisinopril, and I report that to the nurse, or the nurse assesses that on start of care, and they call the doctor and let them know, we double check the dose, and they're taking the correct dose according to what's on the bottle, and they're still having some side effects, which is that dry cough. In that case, it would be an adverse effect. All right, and that's different than a poisoning. A poisoning means the drug was given with either ill intent or they just had an accident, okay? So with a poisoning, something's wrong. Either they're not taking the drug correctly, they're taking too much of it, or they're taking it more often than they should, or they're taking it by the wrong route. All of those would be poisonings. And so what we have to figure out with poisonings, if it was accidental, Was it intentional self-harm, or was it an assault? Now, one thing I will tell you about assault, according to the guidance in ICD-10, we are to assume it's accidental unless we have provider documentation that it was something else, like assault, okay? So don't just willy-nilly assign assault on a poisoning. It would be accidental unless there's documentation telling you otherwise. And of course, underdosing is just that, taking less than the prescribed amount. Now, after you get past the table of drugs and chemicals, there is another alphabetic tablet, and that is the index to external causes of injuries. It's the final part of your alphabetical index. It's found after the table of drugs and chemicals, and this is the list that you're going to use to find codes in Chapter 21. The external causes classify environmental events, circumstances, or conditions as to the cause of the injury or the poisoning or the adverse effect. And the example I give you here is V93.32XD, fall on board fishing boat, subsequent encounter. So let's say that my patient, who is now retired and thankfully able to go do his favorite thing in the world, which is fishing, and he ends up slipping and falling in the boat and fractures a hip or a leg or whatever else is going on. We would, of course, code the fracture with subsequent encounter as our 7th character, but we also have the ability to add, and we are encouraged but not required to add, an external cause code. So we could also add somewhere down toward the bottom of our secondary diagnosis list this code V93.32XD, a fall on board a fishing boat, subsequent encounter. Now, what that will be able to do is help paint the picture of why the patient needs therapy services. Before he had this hip fracture or whatever's going on, he was able to get out and move around and even go fishing. And now he's homebound, so he wants to get back to the point so he can go fishing. And so our therapy services are going to be needed to help him get back to that prior level of functioning so he can continue to enjoy fishing and hopefully be a lot more careful next time, right? All right, so let's talk again about proper beginning. So you know what the parts of the code book are. We know that we're going to try and find the correct codes from the code book and not just mappings or gems or a pick list. And if you don't know what mappings or gems are, that would be kind of like a translation table where you put in an ICD-9 code and it spits out an ICD-10 code for you. Now, the reason that's not a good idea, first of all, is because there is no one-to-one mapping from ICD-9 codes to ICD-10 codes. Several codes in ICD-9 may be needed in order to use only one code in ICD-10. So, for example, that diabetes code that we used earlier in the presentation, diabetes mellitus with diabetic retinopathy and macular degeneration. In ICD-9, that took 3 codes. And so if you tried to map that to an ICD-10 code, it wouldn't be a direct translation. It wouldn't be, they're going to all 3 map to that same one code, for example. So for that reason, you need to really use a code book because it's not going to be accurate if you use mappings and gems when you're trying to translate codes. So to code properly, we're going to start here. And the first rule is to use both the alphabetic index and the tabular list when you're locating and assigning a code. Remember, the alphabetic index does not provide the full code, and the selection of the full code, including your laterality and any 7th character, can only be done in the tabular list. In the alphabetic listing, remember to select a diagnosis code. You first find it in the alphabetic index. Then you verify the code in the tabular. You read all the direction around that code in the alphabetic and the tabular, and read all the directions before you choose a final code. For example, if you have a code book, let's turn together to M1A in your tabular in the chapters part. What you're going to notice at M1A is that the codes with 3 characters are the headings of that category. For example, M1A is a heading of a category called chronic gout. Categories may be further divided by 4th and or 5th and or even 6th characters to provide more detail. A 3-character code can only be used if there's not further subdivisions. So if your code book, if you didn't have one, this is what it would look like. M1A is the category, chronic gout. M1A.3 tells you this is chronic gout due to renal impairment. That's your subcategory. And then M1A.31, chronic gout due to renal impairment shoulder. That's a subcategory. At M1A.31, you'll notice out to the left of that code, there's a little indicator that tells you this code requires a sixth character to show if it's left or right. So your final character would have to be either M1A3110 or M1A3111, depending on if it's the right or left shoulder and if there's TOFI or not. So when you have to add a sixth and seventh character, like in this case, we not only had to add a sixth character, we chose M1A.311 for our sixth character to show it's the right shoulder. And then you notice at M1A.311, there's a little character denotation to the left of that code that requires a seventh digit or seventh character. And you have to go backward to the M1A category until you find a box that outlines that seventh digit option. And by the way, those boxes for the seventh character, they are usually at the M1A category level, but occasionally you'll see a box before that. So anytime you see the gray box with seventh character choices, make sure you look at the instructions around that box to see what code category those are supposed to be used in. And that way you get some clarity as to if you're at the right spot or not. Okay, so again, your final code in this example would be M1A.3110 or M1A.3111, depending on whether or not there's TOFI. And I can't say this enough. If you leave this webinar today and the only thing you learn is on this slide right here, number 37, you're going to code better than you are now. Probably 90% better than you did when you started. Again, the coding guidance I want you to remember is to do the following things. Always start in the alphabetic index first. And note that the dash at the end of the entry in an alphabetic index means additional characters are needed. You also need to check for guidance that says see or see also. And when you see that, don't treat it as a suggestion, treat it as a command, because sometimes if you see an entry at see also, it will direct you to a similar code in the alphabetic index that may or may not have more accurate information for what you're looking for. The next step after you found the code in the alphabetic index would be to double check the code in the tabular index. Again, those are the chapter sections of the code book. And once you're in the tabular index, you're going to check for guidance in 3 additional places. One is the chapter block level. The second place to check is the 3-character category level. And the third place is the final code level. So let me elaborate on that a bit more. At the block level, each chapter is divided into blocks of similar diagnoses. They're listed at the beginning of each chapter. So if you go into chapter 1, the AB codes, you're going to notice right after the heading for chapter 1 on the first page, there's going to be some guidance, and then you're going to see all the chapter blocks laid out. So guidance is often listed at that chapter block level. For example, in your code book, if you turn to the chapter block for I-10 to I-15, these are your hypertensive diseases, you're going to see that above the I-10 category level, you'll see some guidance there. And the guidance will say, for example, use additional code to identify, and underneath that you're going to see where it lists exposure to tobacco smoke or patient's history of smoking or active smoking and nicotine and blah, blah, blah. So what that tells you, it's an example of guidance at that block level. And the guidance here applies to all codes from I-10 to I-15. So if I'm coding hypertension according to the guidance in this code book and the code set and the official guidelines, which is basically what we're looking at when you're looking for guidance throughout the code book, the official coding guidance rules tell me that if I'm going to code hypertension or hypertensive heart disease or hypertensive chronic kidney disease, which are those codes between I-10 and I-15, that we are supposed to use an additional code to identify if the patient has been a smoker, or they've been exposed to secondhand smoke, or they've been exposed to smoke on their job. Maybe they were a bartender in a bar or a waitress in a bar where smoking was allowed, and they were exposed to that. There are specific codes that we have to add, and use additional code means that we have to sequence it right after the hypertension code. So, again, if you're just picking from a list, you're going to miss that guidance, and you wouldn't know that you're supposed to code that information. So again, this is just another example of why you need to have a code book, why you need to make sure that you're looking for guidance in all the different places. This is the only place that this particular guidance will be listed for the codes I-10 to I-15. So we've double checked now in the tabular. We are going to code maybe an I-11 code. We have to flip back to the chapter block level, I-10 to I-15, and lo and behold, there is some guidance that applies to this code I-11 that we're choosing. The next place you're going to check for guidance is at the category level. Each of the codes have a 3-character category. Now, some categories have subcategories, but not all codes do have subcategories. Now, the subcategory codes, if they apply, are more specific than the 3-character category code. But often you're going to find guidance at that 3-character category level. For example, if you flip with me in your code book to the E08 category, that's diabetes mellitus due to underlying condition, what guidance do you see there when you flip over? What you're going to notice if you don't have a code book with you is that at the category E08 level, there is guidance that tells you code first the underlying condition such as congenital rubella, Cushing's syndrome, cystic fibrosis, or malignant neoplasm. And then it also tells us to use an additional code to identify any insulin use. So what we know, if we're looking up a code for E08, and by the way, I didn't put it in the slide, I apologize, codes at the E08 category level are diabetes mellitus due to secondary condition. So what we need to know from guidance in this case is that even though we are in to see this patient for diabetes teaching and new med changes, and maybe we're going to teach them on how to give insulin, because this is an E08 in this case, the patient has diabetes because of cystic fibrosis perhaps. Even though diabetes is the primary reason for home care, we remember our OASIS C1 tells us we have to follow coding guidance. And the coding guidance in this case tells us that we have to first code the underlying condition. So even though we're there for diabetes teaching, diabetes E08 would not be our primary diagnosis. In this case, cystic fibrosis, one of the codes from E84, would be listed as primary, and then the E08 diabetes code would follow. So again, this is something if you're just picking from a tickler list, you wouldn't understand because you didn't have this guidance to factor in, which is again why you need to make sure you have that code book, okay? Use additional code to identify any insulin use. That means that somewhere down the list you have to also add the insulin. Now, sequencing, and we're going to get into that in just a little bit, there's some sequencing guidance built in as far as what code first means, or use additional code, or code also. There's some sequencing rules that apply to those, and we're going to go over that as well. But in this case, again, when it says code first, it means literally that you have to put the cystic fibrosis ahead of the E08 diabetes code, and use additional code in this case means you have to also code the insulin use if it's applicable, but it does not have to be sequenced right after the E08 code, which is good because it frees up the top 6 blocks for our case mix diagnoses that might be applicable. So if we had 7 diagnoses in this case, the insulin use could be in the 7th position because there's no sequencing that tells us it has to go above something else. You're also going to notice at the E08 category level, there's a guidance that says it excludes drug or chemical-induced diabetes, which is E09. And what that means is you couldn't code an E08 code and an E09 code at the same time because the patient can't have both types of diabetes, okay? Now, the final place you want to check for guidance is the final code level. Now, once the final code is selected, you're going to check for guidance at that final code. For example, if you look in your code book at G25.1, that's a code for drug-induced tremor. So let's say you're seeing a patient, they have some psych issues and they have tremors now, they can't feed themselves, they're falling, and the Depakote or Depakine is actually what's causing the tremors, okay? In this case, we would need to look up the codes, and we've found the code for drug-induced tremor, G25.1, and we look up in the tabular section. We looked at the chapter block level, there wasn't guidance. We looked at the 3-character category level at G25, we didn't find guidance, but lo and behold, at G25.1, that final code level, there's some guidance there. And that guidance says, use additional code for adverse effect, if applicable, to identify the drug. And most of the time they're going to be kind enough to at least guide you as to where that code is found. In this case, it would be one of the codes from T36 to T50 with the 5th or 6th character noted as 5. Now, when you look that up, what that's telling you basically is if you're going to code G25.1 drug-induced tremor, the official coding guidance tells us we're going to have to go on our table of drugs and chemicals and find the column for adverse effects, and we're also going to have to find the drug Depakote or Depakine. Usually it's going to be found, by the way, on the drug table by generic name or the drug classification. So you have to find that on the left side, and then at the top find the adverse effect on the table. Where the two intersect, that's the code that you're going to use. And in this case, it will be a T36 to a T50 code, okay? So again, if you didn't have the code book and you didn't know the guidance, you wouldn't know to add that additional code for the adverse effect of the drug. So again, as far as sequencing, what does that guidance mean? Code first means when conditions have an underlying etiology and multiple system manifestations, the underlying condition must be sequenced first. For example, if you look up diagnoses codes for Alzheimer's disease and dementia, you're going to see guidance that says code first the underlying disease. So what that means, these in this case is a manifestation code, and Alzheimer's disease is the underlying condition, and dementia is a manifestation of that. So what you'll see when you flip over to dementia in diseases classified otherwise, there will be guidance that tells you you must first code the underlying disease process, and it will say such as Alzheimer's disease. So again, that tells you have to code Alzheimer's first, and then dementia has to follow right after it. Now, some conditions are not part of an etiology manifestation combination like Alzheimer's and dementia, but they do still have some sequencing rules. In that case, you're going to see a code listed after use additional code guidance, and we have to follow some sequencing guidance. For example, if you look up type 2 diabetes mellitus with diabetic chronic kidney disease, underneath that code it's going to say use additional code to identify the stage of the chronic kidney disease. So again, that lets us know that even though it is not an etiology and multiple system true manifestation, we have guidance that tells us the stage of chronic kidney disease must follow right after that diabetes with diabetic chronic kidney disease code. If we put another code between them, then we're going to not be following coding guidance, and that's going to trigger out a flag for us. You'll see another type of guidance for sequencing, and it will say code also. That means that two codes may be needed to describe a condition, but no sequencing direction is given. If you look up insomnia due to other mental disorder, when you find that code in the tabular, it will say code also what the mental disorder is. And just like we saw in the previous slide on the E08 code for diabetes due to underlying condition, code also the insulin use if applicable, then that means we would sequence it just wherever. You don't have to put it right after the other codes. Code also means that no sequencing direction is given. Now you're also going to notice in your code book as you're learning to code properly, there are some abbreviations in the alphabetic index and throughout your tabular. One of the abbreviations you will see is NEC. NEC means not elsewhere classifiable, and it represents other specified in the alphabetic index. So what that means is if you're looking for a code and a specific code is not available for that particular condition, The alphabetic index directs you to use an other specified code from the tabular. Let's put that more in layman's terms. If you have more information than you can find a code for, then you're going to use not elsewhere classifiable. For example, if the doctor tells you that the patient is having stable angina after a heart attack, you can go in and find atherosclerotic heart disease with unstable angina or with spasm or with other types of angina. That would be what they're talking about here. You have more information than there's a code for. There's not actually a code for atherosclerotic heart disease with stable angina. So we have specific information as to what kind of angina it is, but we don't have a code for that specific information. We're going to choose NEC or other specified in that case. Another example would be H26.8, other specified cataract. That means that if we're going to use this code, we have specific information, but that specific information does not apply to any of the other kinds of cataracts that are listed in H25 or H26 categories. Another abbreviation you'll run into quite often is not otherwise specified, or NOS. This represents unspecified or its equivalent. We want to, of course, avoid the use of unspecified as much as possible. What unspecified tells you is that you don't have enough information to code anything more specific. So before we add those codes, we want to do our best to try and get the information, either from assessment or querying the physician to get more specific information. And once we've queried and documented that call and wrote down who we spoke with and all of that, we can use a more specific diagnosis. But sometimes either the physicians are not going to be getting back with us timely, or we just can't get the information that we need to choose a more specific code. We would have to use an unspecified code in those cases. The coding guidelines want us to code to the highest level of specificity known, so you can only code the things you know. If you don't know, then you would have to use an unspecified or NOS code. The use of those codes, however, can impact your case mix revenue in some cases. Usually an unspecified code is not going to give you case mix, whereas more specific information would. So again, that's why I recommend that you start trying to query. And again, even at referral, when you start getting information, if you see it's really non-specific, start calling and inquiring and getting information up front, because we only have 5 days from the start of care assessment to complete our information gathering. And so if we don't get that information back within that 5-day period, we are not supposed to use that code according to CMS guidelines, at least not for that OASIS. If you get it, let's say, on day number 10, you should have already had that OASIS completed at that point. The assessment gathering period is over. If the patient goes out and comes back at the next OASIS, you can go ahead and use the diagnosis at that time, but you can't use it on the start of care, for example. So keep your timelines in mind as you query as well. An example of NOS at I50.9, we see heart failure unspecified. That means that we know they have some kind of heart failure, but we don't know if it's systolic or diastolic or if it's chronic or acute. All we know is that it's a type of heart failure. And you're going to see under that entry where they've abbreviated, for example, congestive heart failure NOS. So if all you know is that the patient has congestive heart failure, you don't know if it's acute or chronic or acute on chronic or systolic or diastolic or whatever. This lets you know you're in the right place, but the NOS means just that, not otherwise specified. You'll also notice it at I49.9 for arrhythmia, not otherwise specified, or cardiac arrhythmia unspecified. In that case, you only know that they have some kind of heart arrhythmia, but you don't know if it's AFib or if it's PVCs or PACs or what's going on. So if you can't get more specific information on a query of some sort, then you would only be able to code the unspecified code in that case. All right, you're going to also notice brackets and punctuation marks in your code book. The brackets are used in the tabular index, and we know the tabular is in the chapters of the book, in the back of the book. The brackets there are used to enclose synonyms, alternative wording, or explanatory wording. For example, if you look at code A48.2 in your tabular, you're going to see that it's listed as non-pneumonic Legionnaire's disease. And in brackets, you'll see Pontiac fever. What the brackets are telling you is that you may also call this disease Pontiac fever, but it's the same thing. You're in the right place. Now, brackets in the alphabetic index are used to identify manifestation codes. So it's a little bit different meaning in the alphabetic, in the front listing of the book. If you look at disease, Lewy body, dementia in your alphabetic listing, you're going to notice that Lewy body dementia will say G31.83, and then right after that code in brackets is an F02.80 code. What that's telling you is that the F02.80 is a manifestation code, and that those two codes have to be coded together. Code first notes are noted above in red at the F02 category. So if you're not sure which one goes first, when you look up both G31.83 and you look up F02.80, you're going to notice at the F02 guidance at that 3-character category level, it's telling you to code first the Lewy body disease, the G31 code. So if you're coding from just picking from a list, you're going to be coding improperly. All right, another type of punctuation you're going to notice in your code book in the guidance is parentheses. And parentheses are used both in the alphabetic index and the tabular to enclose supplementary words that may be present or absent in the disease statement. And those are referred to as non-essential modifiers. For example, if you look in the alphabetic index under the word abscess, you'll notice that right by that word abscess in parentheses, there are several different types of modifiers. It may say infective or postoperative or whatever. It's just letting you know that all of this applies to the types of abscesses that you find here. Okay. Another type of punctuation that you'll see is a colon. And colons are used in the tabular list after incomplete terms that need one or more of the modifiers that follow the colon to make it an assignable code to a given category. For example, if you look at G01, you're going to find notes there at the G01 category, and there's an excludes one note that says meningitis in gonococcal or leptospirosis, for example. And what that's telling you is unless the meningitis is one of the types that are listed after the colon, you're not in the right place, okay? Now, when you see the word and in a narrative statement in your code book, it means and or, okay? So just keep that in mind when you're talking about coding guidance and coding statements and all of that. I'm not talking about the physician's narrative, but the narrative parts of your code book and the code set, and means and or, okay? Other codes or other specified codes, again, those are for use when the information in the medical record provides detail for which a specific code does not exist. And you'll find that in the alphabetic index with NEC in the line. That means it's saying other or other specified when you get to the tabular list area. Unspecified codes, again, just to reiterate the difference between unspecified and other. Unspecified codes, or when you see unspecified or NOS, those codes are used when you don't have enough information to assign a more specific code, okay? One thing that you're going to notice as well when you get into the tabular section of your book, there are inclusionary and exclusionary guidance there. So includes notes appear immediately under a 3-character code title in the tabular list. They further define or give examples of the content of that category. You're also going to notice there are 2 types of excludes notes in ICD-10, and I say that because in ICD-9 there was only one type of exclusionary verbiage. In I-10 there's 2 types, excludes 1 and excludes 2. Excludes 1 means stop. This is not coded here. It means the title or the diagnosis title heading and the diagnoses listed in the excludes 1 diagnoses are mutually exclusive, and that you should never be coding those 2 diagnoses at the same time. For example, if you look at the guidance at category E10, type 1 diabetes mellitus, you're going to notice an excludes 1 note that says diabetes mellitus due to underlying condition E08. Now, why is it telling us that? Why are they excluded? That's because you can't have diabetes due to cystic fibrosis and type 1 diabetes at the same time. Yes, they most definitely both use insulin in most cases. With E08 is what I'm talking about with most cases. E10, they always use insulin, right? So what they're telling you there is you wouldn't have an E10 code and an E8 code on the same claim because they're mutually exclusive. You have to choose one or the other. Excludes 2 is more of a caution note. It means that the code title here does not represent the codes that are listed below the excludes 2 notation. However, if the patient has both conditions at the same time, it is acceptable to use those codes in the excludes 2 note and the code above it at the same time. So, what do you follow? If you see guidance in your code book up in the alphabetic index section, and then you see guidance over in the tabular, and then you've just learned some general guidance, which one do you follow? So the actual conventions and instructions of the classification take precedence over general guidelines. So what does that mean? The instructions at the tabular level is actually called conventions and instructions, whereas general guidelines are the general rules that we use. So CMS was kind enough to give us information on coding criteria, what we're supposed to factor in when we're trying to select the correct code. And what they tell us is, number 1, again, we must comply with those coding guidelines. We are to code only unresolved diagnoses. So if the patient, for example, had their gallbladder removed because of cholecystitis, we don't continue to code cholecystitis. We're going to have to code aftercare of surgery on the GI system in that case, right? Because the cholecystitis was resolved by the surgery when the gallbladder was removed. We're told we should only code relevant medical diagnoses. So if I'm out seeing the patient for wound care after an automobile accident, and that patient happens to be positive for human papilloma virus, HPV, I wouldn't need to code that. It's not relevant, right? Because we're not going to be doing anything that would impact our plan of care as far as HPV goes, for example. So only those things that are relevant. And we are supposed to code only diagnoses supported by the patient's medical record documentation. Now, I will clarify that statement to tell you this. When it talks about supported by their medical record documentation, that doesn't mean what the field clinician puts down. The medical record documentation, what it's talking about there is if you're going to be putting down a diagnosis, you need to have physician or provider medical record documentation that you're using the correct code. We can't just start putting codes down because the patient history says that's what they have. And by patient history, I mean verbal patient history in that case, or because they have a certain medication in the home. For example, if they're on an antidepressant in the home and you don't have anything in your clinical records from the physician or the provider that says the patient is depressed, you wouldn't just assign depression as a diagnosis code. The reason for that, of course, is number 1, you got to query the physician to find out why they're on the medication. And yes, most of the time it is depression, but we also know antidepressants can be given for multiple other reasons, such as anxiety or smoking cessation. So if we just willy-nilly add a diagnosis of depression, we've just given the patient a disease that they don't really have. So we must clarify and make sure that we have supporting documentation in the patient's medical record. Now, I'll also tell you this. If you don't have it printed from the doctor or on an order or something like that, what you do when you go and query the provider, call up and find out what's going on or fax over a list of different possibilities. And then when you get that information back, you're going to want to have some kind of coordination of care note in your records that show, for example, if I made a phone call, I would be calling over at Dr. Timothy Shepard's office, and I spoke to Ashley Bolton, LVN, and clarified whether or not the patient had depression because they're on Wellbutrin in the home. And then Ashley would say, yes, I went and asked Dr. Shepard, and yes, the patient does have depression. I'm going to document that call, the date, the time, specifically who I spoke to in the office, and which doctor's office that was. All of that documented in the chart would be okay to support in the medical record. And if you wanted to go so far, if your policies tell you that you should, and you may want to pull policies and see what yours says, some agencies require that would also be written on a physician's order, telephone order, and the physician would have to sign it. And not every agency goes to that extent, so just check your policies to see what requirements you have to follow. But you definitely want it documented in the medical record who you spoke with if you're clarifying. Okay, and then we also know that according to CMS's coding criteria, we must ensure compliance with sequencing requirements. In that case earlier where the patient had hypertension and they were a smoker for 20 years, we know that we would have to sequence the history of smoking right after the hypertension code. So we have to ensure compliance with those sequencing requirements. We also have to make sure the etiology and manifestation codes are sequenced and reported properly. So in the case of our Alzheimer's dementia, we would have to make sure that the Alzheimer's disease code would go before dementia and other specified diagnoses. Last, we want to avoid nonspecific or ambiguous diagnoses or symptoms when possible. The criteria for primary diagnosis, according to CMS guidance in Appendix D and subsequent articles of guidance, they tell us that the primary diagnosis is most related to the current home health or hospice plan of care. If more than one diagnosis is being treated, it would be the diagnosis that represents the most acute condition and requires most services that should be assigned as your primary. It's the chief reason for home care or hospice, and it requires the most intensive skilled services. We also have guidance from CMS regarding secondary diagnosis sequencing, and it tells us when we're selecting a secondary diagnosis or diagnoses, we are to consider the following criteria. We would only use a secondary diagnoses if they didn't meet the criteria for primary diagnosis, for example. The secondary diagnoses that are selected are addressed in the plan of care, and they affect the patient's responsiveness to treatment and rehab. And last, we're to list those in the order that best reflects the seriousness of the patient's condition and to justify the disciplines and the services provided. In conclusion, I again want to thank you for being with us today on our webinar. Stay tuned for further coding webinars regarding ICD-10. We're going to, again, be going through a whole series here, and you're going to learn the specifics of coding in different types of diseases and disease classifications, such as diabetes and respiratory and fractures and musculoskeletal and so on. So just keep updated by looking at the Axxess website for training, webinars, on-demand webinars, and the series will explore coding different diseases and body systems, including the guidance that supports coding for each of those. So stay with us with Axxess. Let's continue to succeed together, and I really appreciate you being with me today. If you have any questions in the meantime, you can send those questions to me. For more information, you can contact me by phone at 214-575-7711, extension 3917. Or you can email me at jgibson@axxess.com. And I thank you very much for being with me today. Have a wonderful rest of your day or evening or whatever time it might be. Okay? Thank you. Bye-bye.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. Axxess is proud to offer a variety of resources to supplement your training and keep you in the know of industry news and updates. You can register for additional training webinars through our software or sign up to attend a live seminar on Axxess.com. We also provide tutorials, online training manuals, frequently asked questions, and on-demand videos through Axxess.com. Our expert support representatives are from this industry and have been in some of your shoes. If you'd like to speak directly with one of our representatives, we are just a call or a click away. You may call us at 800-795-5900 or email us at support@axxess.com. Now that we've given you all the great tools to make you an expert, Join the conversation and connect with us on Facebook, Twitter, Instagram, Google+, and LinkedIn. Here we will keep you in the know with industry news and Axxess happenings. Thank you for your time today and for choosing Axxess, your partner providing the knowledge that empowers you to grow your business.